both from the state as well as private providers. So there's a strong need to really go forward towards universal health plan for India. So now I'll request Dr. Amitabh Gupta to talk about global best practices in terms of coverage models and all the implementation requirements to achieve UHC as well.
Hi, good afternoon. Nishant, you're absolutely right. I think India is a very complex country, and all these schemes somehow seem to coexist together without any interference from anybody. Right. Healthcare today, as mentioned by my colleagues, is not just about cost, access, and quality. Now, there's a fourth dimension to it, and which is the protection. And this is the financial protection which I'm talking about. Let us know about some of the, where's the cursor? Let us look at some of the existing models of healthcare across the globe and adopted by different countries. The first one is the beverage model. It is financed and provided by the government through a tax mechanism. Here I'm trying to talk about what kind of shape and form our universal health coverage can take. And so we need to know a bit in detail as to how it's followed globally. It's of course not for profit. Primary care physicians, they act as gatekeepers, as Nishant was talking about. And this is what insurance requirements are as of today. Full access to all, regardless of ability to pay. We are talking about equitable healthcare to all. Low cost per capita, as the government is the sole player controlling the charges of the doctor, is used at Great Britain, UK, Denmark, Finland, Spain, Sweden, Norway, and other countries. The another model is called Bismarck model. This uses an insurance mechanism, and insurance is sometimes referred to as sickness funds. It's financed jointly by employers and employees through a payroll deduction. So it's contributory. It's of course not for profit and covers everybody. Doctors and hospitals here are more private than of government. There are tight regulations, and the government has an absolute control over these schemes, used at Germany, France, Belgium, Netherlands, Japan, and other countries. Then we have the national health insurance model, which is basically a combination of both the models. And it's basically the program is run by the government and is funded by citizens. There is no financial motive here to deny claims. It's not for profit. The single player has considerable power to negotiate cheap market prices. In fact, in Canada, they have been able to reduce the prices of drugs to a very large extent. The universal insurance programs are, of course, cheaper and simpler than programs which are meant for profit. The lacunas are that they control the cost by limiting the medical services which they pay for, and the waiting periods are pretty high, followed at Canada, Taiwan, South Korea. This is the model which is the out-of-pocket model. Currently, we are trying to see if we can come out with a universal health scheme. This followed in about 160 countries out of 200, and basically in the developing countries. These countries mostly lack an organized structure of or financial resources. The rich is able to get proper medical care, while poor are deprived of tertiary care, medical care, or depends on where they are. Now, this is followed at Africa, India, China, and South America. The United States health model is the most complex and is basically a mixture of many schemes and many models and various systems. So if I look at healthcare spends today across the world, the United States is highest with about 17% of healthcare on percentage of healthcare expenditure, which is the GDP. India is only at 4%. These are the World Bank statistics. A lot of European countries have also a significantly higher percentage of GDP expenditure on health. So India ranks today amongst the bottom 5 nations in the world if we talk about public health spending, and which is today only 20% of the GDP which I talked about is the spent by the government. Of course, they are talking about that in the 12th plan, they will go up to 2.5% of the GDP, but this remains to be seen. As per WHO standards, we are really far lacking behind as far as hospital bed density is concerned. Why I'm talking about all this is because once we have UHC in some form or the other, we will require a lot of hospitals, we will require a lot of medical professionals across India to cater to this huge demand which would come up. This is the population across India as of today. We see about 28-29% of the population is below 15 years. The next bracket, 15 to 24, is about 18% of the population. 25 to 54 is about 40.60%. Now in insurance, we've seen that basically most of the healthcare is required between 45 to 55 age group. And 65 years and above is about 5.8%. But what we see here is that by 2026, 17 crore of our population would be above 60 years of age. And why I'm again trying to show you these statistics is that the age group is increasing, the population is aging, and there's an increased burden of chronic diseases, which primarily means that a financial protection is required, and therefore not everybody actually would have access to care because of financial restraints. But here is a huge demand for universal health coverage. Today about 70 or 80% of our spends are out of pocket due to inadequate financing of healthcare. The healthcare in itself is very highly fragmented. We don't have a regulatory body today over providers. A certain percentage of our population falls below poverty line, or they have to borrow money for financing their healthcare needs. And this is a huge percentage, or at least in numbers. A majority of our population today still lives in rural areas. Somebody was talking about or showing statistics, and which was about 60% of our population still in rural areas. And look at the kind of treatment they get. It's basically, more of it is traditional or some unrecognized forms of treatment which are available at those places. So the insurance network today, as of today, is that non-life insurance company, which also sell healthcare or health insurance policies, are about 24. We have life insurers, which are about 24 again. They sell health by way of riders. We have 4 health insurance companies which sell only health. And we have 30 TPAs across India to cater to all the requirements of the entire population, which is covered through various health insurance schemes. Now, if I look at the kind of population which is covered through all the schemes, is that CGHS, we have about 0.4 crores. ESIC, we have about 6 crores. State government funded schemes are about 11 crores. We have 14 crore of our population insured through RSBY, which Nishant was talking about. And we have commercial, retail, and group, which is the insurance part of it, is about 6.4 crores. So about 30% of our population is currently insured. But then what happens to the rest of, okay, I'm being shown that I have, I think I'm out of time. So these are the various schemes which are currently in India: ESIC, CGHS, corporate schemes, as far as the organized sector is concerned. For an unorganized sector, we have insurance schemes run by various insurance companies. We have UHIC, which was launched way back in 2003, which was 1 rupee a day scheme. We have self-funded groups and a lot of state schemes like Rajiv Arogya Shri. We have Tamil Nadu scheme. We have a lot of others. The vision for universal health coverage is that entitlement to every citizen, guaranteed access, both primary and inpatient care, and the choice of facility. That's the vision. These are the funding stakeholders in the implementation part when it comes to it. We are looking at either state governments, central governments, some NGOs, World Bank, corporate social responsibility activities, individuals funding it themselves through some mechanism. The implementation stakeholders could be trust, insurers, or TPAs. And the service providers, of course, we all know would be hospitals, whether public or private, diagnostics, and pharmacies. The requirements are, of course, this is one of the most crucial part, the unique identification number, whether it's going to be Aadhaar or whether it's going to be fingerprinting or whether it's going to be a card, which is going to be a transactional card. Data capturing. The data has to be captured in a coded format, and then it has to be stored in some manner, and possibly an EHR which would record all the transactions. Contracting and negotiating with hospitals is going to be very essential by way of either DRGs. We are looking at either package pricing, fixed lump sum costing, per diem pricing, or whatever we come out with. One of the requirements for rollout of this massive scheme would be, and the requirements would be availability of adequate infrastructure across India, because then the government would be responsible for providing care everywhere across India. A huge amount of skilled health force would be required, affordable drugs and diagnostics, and technology-driven platforms, which is the topic today, of course. We are looking at this scheme probably would be could be the single largest purchaser of IT in India in times to come. I'm not getting into EHRs, primarily everybody has talked about, but the benefit from an insurance perspective is, of course, continuity of care. All these records would be available. No need for resources to do manual entry data, and the filing cost, storage costs, basically would be saved. The IT framework could look something like this. All this data from everybody could flow into a central repository, and from the central repository, the medical data could go into the EHR, and the non-medical data, which is basically meant for payments from payers, could go to insurers, TPAs, or trusts. Expected outcomes. Of course, we are looking at greater equality, improved health outcomes. We're looking at accountability and a very transparent system. Because of financing mechanism, there is going to be reduction in poverty. Productivity is going to increase. Jobs would increase. And multiple TPAs or insurers or trusts would have to work under one common umbrella for the administration. And we are looking at a sustainable financial model and timely payments to all various stakeholders. I think that was a takeaway for the government. Thank you.
Thank you, Dr. Abhita. Now, I'll just ask the panelists to take about minute time and summarize the roadmap for action, so which will be presented to the government as part of the HIMSS report.
Yeah, thank you very much. I would say two things. One is that there is a clear identification of what role ICT could play in universal health coverage. So perhaps learning from what knowledge and evidence is available at global level, all stakeholders in India can come together and develop and design and identify what and how that existing knowledge could be utilized to progress toward universal health coverage in India. That's one. Second is, I would say that this could be achieved if we are very systematic, or if, for example, India should, in my personal opinion, consider developing a national e-health strategy, which will clearly outline that how and why, what time and what possible role ICT would be playing in moving in direction of increasing access to population, services, and financial protection. Summary, 2 points. learn from global experience and adopt for the country, develop a national strategy, call it whatever, which outline with the timelines and clear roadmap. Thank you very much.
Thank you, Jay. If I have to summarize, I will say 2-3 points. One, I agree with Chandrakant that there has to be a national vision and strategy for the government, which is not at a very high level, that will increase their spending to 2.5% of GDP, what Planning Commission report says. But that will not help. It has to be a more action-oriented vision with clear timelines and who will do what. Second is that a part of that could be there should be a national body, maybe within Ministry of Health itself, but there has to be a separate body which has to lead the whole process. If you expect that bureaucrats who have so many other things to do will also do this, it's difficult. So it has to be a separate body, and countries across the world which have got success in UHC have taken this route where they have set up a separate body which manages the whole thing. And the third is that you develop a good framework for linking with the private sector. You know, you don't consider them as from the government side that, you know, they are separate and we are separate. It has to be a strategy where how do you link with the private sector? You create a strategy so that you can use their strength, but at the same time, government can act as a purchaser, and not only from the private, but even from the public, why not? Where you can then talk about the quality, standard treatment guidelines, protocols and things like that, which can be done through this kind of mechanism. Thank you.
I think most of it has already been talked about, but what I can say is that as and when it happens, I think we could be looking at some really exciting times, and I think health insurance could be used as a funding mechanism for healthcare in India, and that's how it has happened in the last decade by and large. We've seen a lot of hospitals, better facilities coming up. We have seen doctors who were not willing to stay at rural areas or villages or smaller towns and cities have gone back, primarily because now the patient is able to pay through an insurance mechanism. So I think we'll look at some very exciting times as and when it happens. Thank you.
Thank you. Now we'll open up for questions.
I'm Dr. Sanjeev Sood from Institute of Liver and Biliary Sciences. All the three panelists have used the term universal health coverage, whereas the objective is universal health care. So it looks like that the objective is you're using the means of insurance solely to achieve the goal of universal health care. So the message one gets is that the out-of-pocket expenditure or the individual expenditure or for that matter, the co-payments will totally be eliminated. They don't fit into anywhere in the scheme of things which you have shared with the audience. That's point number one. And secondly, what Chandrakant has brought out, the framework and the indicators and measures, though the Indian statistics are available, but they have not been shared in the overall framework. And where does India rank in its journey towards attainment of the universal health coverage? From the barriers which you have shared with the audience, it looked like that it will be possible only if there is one super authority, super health ministry, and healthcare is not a concurrent subject to be implemented by the states as well. So with these issues, it looks like a utopian dream.
Thank you very much. Very pertinent points you raised. My idea of presentation or showing those slides was give a context that this is what could be done. I deliberately did not use Indian data because from different sources, different data comes which is contested by everybody. So that's a debatable issue. The entire point here is to deliver is that this is what could be done, harmonized, achieved through ICT platform. That's one. Second point you raised about what mechanism would be used for UHC. This famous philosopher Groucho Marx said that it doesn't matter whether cat is black or white, as long as it catches mice. Similarly, it doesn't matter what mechanism adopted, what other countries have done. There could be a mechanism which could be identified by India. What matters is that more people have access to services, more services, and financial protection. Third is not your point, but then I want to highlight that often this discourse, sometimes word universal health coverage and care are used interchangeably. The way we use, like I understand it, care is mainly restricted to only curative component, coverage is much broader. So UHC in a more global terms these days is universal health coverage because it talks about coverage in terms of services, population and financial protection, so cost, so to say. So coverage is, I would prefer to use more frequently. Thank you very much.
Just 2 points. I think one, you very rightly mentioned that if we are talking about an insurance model, then it defeats the whole purpose of reducing out of pocket for the vulnerable families and all. So I will like to clarify at least that we are not saying, I am not saying that the insurance route is the only route to do, and even when you use insurance, who pays for it? That is the second part. So for example, in all these government funded schemes, for poor and vulnerable families, government is paying the premium. So the people who can pay, who have the ability to pay, they can pay from their pocket. People who don't have ability to pay, government pays for them. But whether insurance can be used or insurance like demand side financing mechanism can be used for all type of care, whether it's